So today I'm going to be speaking on the advances in perioperative anesthesia. As little as 10 years ago, almost 90% of patients classified their pain as moderate, severe, or extreme after surgery. And with the evolution of multimodal pain management, that number has dropped drastically. And the reason is there are newer medications which are shorter acting, have fewer side effects, and also have novel routes of administration, which I'll discuss all of those. So what is multimodal pain management? It involves multimodals, different modes, whether it's the ultrasound for radiation, whether it's different medication or different techniques. The medications include simple things like Tylenol, Neurontin, Exparel, which is a new mode of delivery of medication, of Marcaine basically, regional anesthesia, and Decadron, Propofol. The combination of all those things basically decreases the total amount needed if you were to go with just one specific thing. And the purpose of all of this is to try to decrease the amount of narcotics, especially with the opioid crisis that's going on nowadays. So Tylenol, everybody's taking Tylenol, right? You have a headache or a sprain or something, you take some Tylenol. You can take up to 3 grams a day. You can actually do 4, but we usually do 3. It's not an anti-inflammatory, it's an analgesic. It's gentle on the stomach, so you don't have to eat before it. How does it work on pain? Tylenol's been around for how long? No one knows. It's a common theme in anesthesia. They do know where it works for fevers. The next medication is Neurontin, which is also gabapentin, and a lot of the nurses here know that patients come in for orthopedic surgery, they get Tylenol, they get Neurontin, they get a bunch of things. That's the goal of multimodal pain medicine. It used to be used for epilepsy and to treat pain from shingles. It works on a GABA receptor, which inhibits the brain function. So by inhibiting the brain function, it's thought that somehow it affects the pain. Not exactly sure how it works on pain. Gets better. NSAIDs, they know. It can be either selective or non-selective. They are cyclooxygenase receptors, which are either COX-1 or COX-2. They can be selective. Things like Toradol, aspirin, Motrin are non-selective. COX-2 selective medications like Celebrex have fewer GI side effects, so they're a little bit gentler, but they also have their own things. I know if a lot of people remember Vioxx back in the days. It was killing people, so they recalled it. Fortunately, Celebrex doesn't have that profile. Tramadol, it's used more as an outpatient. We don't use it in the operating room at all, but it's a mild narcotic, so it works on mu receptors, which are narcotic receptors in the spine, but it also affects the serotonin and norepinephrine reuptake. How does that part of the function affect the pain? No one knows. It can either work in the spine, in the brain, and we give these medications all the time. And it's like, we know it helps, but how does it exactly work? Exparel, this is one of the new novel ways of administering medications. I like the pomegranate comparison, basically, because it's Marcaine. It's a local anesthetic that's been around for a long time, and they've enclosed it in a liposome. And that gives it a sustained relief. It can last up to 72 hours. Here in the United States, it's for soft tissue administration. In Europe, they're using it for direct nerve applications. So as the fat lipid wears off, it releases those little pockets of Marcaine, and it can make your arm numb for 3 days or so. It can be good and bad. Some people are freaked out by having a numb limb for so long, and they don't want to have 3 days of numbness. But this is one of the new things that has just come out within the last couple of years that's really allowed us to do things like outpatient shoulder replacements. You used to come in and stay in a hospital for 3 days. Now people get this injection, they get a nerve block, they go home the same day. One of the reasons a lot of these people go home is because of the regional anesthesia, because of the nerve blocks. And in the past, we used to stick a needle near a nerve, put some electricity on it, and when the arm would start twitching, we'd say, okay, we're in the right spot, let's give the medicine, and that's how you do a nerve block. Now with the ultrasound technique and the advancements in ultrasound, you could get very specific. You can actually see the nerve, inject the local next to the nerve, and you get a better block with less medication. And with the ultrasound technology, you can use it now in offices, in a hospital, and outpatient centers. On the right there, you have a typical ultrasound machine. And on the left, you could see an ultrasound image. You could see the needle here is the white line coming in from the left. The BP is what we're trying to get. That's the brachial plexus. Those are the nerves that go to the shoulder and arm. And the LA is the local anesthetic. Liquid comes out dark on an ultrasound, so you could see all this liquid here surrounding these nerves and numbing them up. Over the last 3 months or so, we've done over 90 now shoulder surgeries at the surgery center at ONS, and about 84 of them have woken up pain-free, which is a big difference from the 90% 10 years ago that woke up having pain. Of the 6 that woke up with some discomfort, it was minimal. 2 just needed an additional injection of local, and the other 4 required 25 mics of fentanyl, which recovery room nurses here know that's not a lot, or 0.5 milligram or 1 milligram of Dilaudid. So a lot different narcotic requirement after the nerve blocks. Decadron is a steroid. We could give it both IV as well as an additive to the nerve block. It is an anti-inflammatory. A simple, small dose of Decadron IV can help patients with pain and nausea the next day, which is incredible how it can have that effect. If you add it to the nerve block, it can extend the duration of the nerve block anywhere from 8 to 10 hours. So you can have a good 20, 24 hours of comfort after a nerve block without taking medications. Again, medications, the narcotics is what we're really concerned about. It's a very safe medication. Even in diabetics, a small dose of steroids will not increase your blood sugar that much. And it's on the World Health Organization's list of essential medications. Propofol is another medication on that list. It's one of the most effective and safe medications to deal with when administered properly. When administered properly. Everybody remembers Michael Jackson in 2009, and if he would have had an anesthesiologist with him, he may have been here today. It's a very safe medication. It's predictable. It's not a pain medicine, and it's not used for insomnia. It's an anesthetic, and it possibly works on some GABA receptors, like we had mentioned before, and some sodium receptors. Where does it work is what's new and exciting, because they're just finding this out now. Propofol, as well as the other anesthetic, the anesthetic gases and things like that. We've been using them for 170 years. We don't know exactly where they work. So there's this thing called the thalamic reticular cortex, which is like mission control. And propofol and the other anesthetics, on the EEG, you see oscillations in the brain waves that are different from sleep. So going to sleep in the OR is different from going to sleep at home. But you don't want to tell a patient, Mr. Jones, I'm going to put you in a medically reversible coma for a few minutes while you have your surgery, and then trust me, I'll wake you up afterwards. It's easier to just say you're going to go to sleep for a few minutes. So that's a picture of where that thalamic reticular nucleus is. Now I don't know how many people remember this bridge from the 1940s. It's the Tacoma, Washington bridge. And shortly after they built it, they realized that there's a wind tunnel right underneath it. When the wind would get to about 30, 40 miles an hour, the bridge would start oscillating like this. It was quite a sight. It lasted a while before it actually broke. But if you can imagine the bridge being this mission control, this thalamic reticular nucleus, the gentleman on the bridge or the cars going across are the information that needs to get from one side to the other. And the propofol is the wind. Once you get enough propofol, that bridge starts oscillating. That part of your brain starts oscillating. No information is going back and forth. You're asleep. As the oscillation slows down, as the propofol wears off, you start to wake up. But you can imagine the bridge oscillating. This is something that they're discovering now after 150, 170 years of anesthesia. Once these oscillations stop, you start getting a little bit more awake, you get a little bit groggy, and then you wake up. To help you wake up more, to help you wake up quickly, they're starting studies now on giving patients ADD medication, like Ritalin. So you can imagine in the future, you get a shot of Propofol, you go to sleep, you wake up with a shot of Ritalin without any grogginess, and all of a sudden you're home. And this is actually pretty groundbreaking in anesthesia. It's probably Nobel Prize winning work, but we're just starting to realize that after so long. And we use these medications every day, and we don't know exactly how they work, but little by little we're getting there. So the advances basically revolve around these opioid-sparing techniques, using a whole bunch of different medications to try to decrease the amount of pain medication, because the pain medication has effects: nausea, vomiting, constipation, itching. It's not pleasant. So we use short-acting medications with fewer side effects which are non-addicting. That's the biggest thing. And you get a quick recovery of anesthesia. And again, the most exciting thing is the understanding of the mechanisms of how all these different medications work. We use them all the time. We don't know exactly how they work, but we're able to get patients through surgery and get them home. And that's it. Thank you.